operation had taken place. So our experience, I don't have a slide today because I'm not sure whether we are allowed to use a small subset and present it. But just to tell you, we had some 100 cases, absolutely no complication as far as bleeding goes, and no stent thrombosis. So that summarizes the effectiveness of this molecule. So when we talk of antiplatelet therapy, Congadorol is probably the newest entrant. Though I must confess, I don't know. I mean, somebody from MSN must tell us. I believe 85% of the cath labs in US, they use Congadorol as their first choice, while it's reverse in India. I think just about 10-15% of the cath lab use Congadorol on regular basis. Maybe it's a new introduction, and we are still getting used to it. But let me confess that it's one of the most popular drug in US. Nitin, you have any comments on this particular?
You have very rightly pointed out, sir. In fact, the scenario is changing. 2 months back, even the 10% was also not the case, sir. Now I can say that almost the things is changing, and we have reached to the level of 7-8%.
Okay, lovely. So, it's like a kid is born in this country too, and it will slowly make its impact as time goes. But let's see how the effectiveness of this antiplatelet agent has been strongly seen and getting more and more popular. Now, this is a question we always ask when the patient comes to us on CAT table. Most of the time, the boss will ask the resident, has he received DAPT? Previously, we used to specifically ask for clopidogrel, but these days we ask for a specific molecule based on the patient's condition, whether it's acute, chronic, multi-vessel stenting or single vessel stenting, age, any bleeding history in past, and so on. So many times, most of these bigger places where Dr. Kasturi works and I work, they receive patients from periphery. So patient probably has been thrombolized, probably has received some kind of oral antiplatelet. And then you have to make a choice in the cath lab, what kind of antiplatelets are you going to use when you continue an angio into an angioplasty. So when we talk of DAPT, like it could be anything, it could be clopidogrel aspirin or prasugrel, ticagrelor aspirin. And sometimes whenever you preload, it doesn't get into circulation. So when you give these kind of tablets on table, be sure that there is a little gap between the stent placement and these tablets. Most of the time, it doesn't matter because we are covering it up with something else. And many get a bolus of ticagrelor on table. So the tablet must get absorbed, must get into bloodstream, and then you will get the decent action of anything given orally. As I understand, ticagrelor is probably the quickest into bloodstream compared to prasugrel and clopidogrel. Dr. Sridhar, you agree with this statement that ticagrelor is probably the fastest into bloodstream?
Yeah, yes.
Yes. So, I would probably feel most of my procedures are done angio into angioplasty, You load with ticagrelor on table and you continue. Fortunately, by the time ticagrelor is given and your stent goes in, there is generally 1 hour's interval. So you're quite okay on the antiplatelet action. And there are these challenges of oral antiplatelet therapy in a very urgent case. And you cannot give the tablet orally, like patient is in cardiogenic shock, he's on mechanical ventilation, there is therapeutic hypothermia, then patient is vomiting or heavily sedated and cannot swallow because of these. All these, they reduce or delay the absorption of the oral drugs. And this is why intravenous injection would be very precise. The dose is correct. The absorption is not an issue because you're giving intravenous. So I would always trust intravenous medication for such a high sort of intensity treatment of acute coronary syndrome. Now, these are some of the limitations of oral P2Y12 inhibitors, that the drug action absorption is delayed because what patient has had in the previous 1 hour's time. There is a delayed onset of action, thus suboptimal platelet inhibition in the first hour. See, most of the time we are in a rush. I mean, not a rush because Sridhar wants to do 10 cases in a day, but the patient has to get everything in a very fast time, quick time. So the blood supply has to be established, the stent has to go in, and all the clot dissolving medicines also need to go in. The platelet inhibition can be irreversible. Then, of course, there's a delay whenever we give an oral tablet. There is a delay in the onset as well as offset. Like you run into some complication, you have already loaded the patient, and if there is a perforation, that would be a big problem because the offset action is always delayed. Then these cannot provide reliable antiplatelet effects. We all know about aspirin resistance, clopidogrel resistance. We still are not talking about prasugrel or ticagrelor resistance. But I had a 1 hour window, and we did an angioplasty at 1 in the afternoon. Within 1 hour, we did an angioplasty, and we had given ticagrelor, and a 415 proximal LAD stent had a clot formation by late evening. So less than 12 hours, the patient had a clot in the deployed proximal LAD stent. And we couldn't find any reason. So we did imaging from inside, and stent was very well placed, very well deployed. So I feel we would find resistance to the tablets as we go on. And then you can have this drug-drug interaction. So the risk of stent thrombosis is definitely there following PCI with the oral antiplatelets inhibition. Now, the earlier studies, PCI Cure and Credo, there was no clear edge, but there was a suggestion that clopidogrel could be a very important addition or could be a very important way to begin an angioplasty. However, 600 of clopidogrel did not show too much advantage over 300, but there was some kind of hint that maybe you should give 600 in an acute case. Then the current Oasis 600 milligram again reduced the MACE events by 14% and stent thrombosis by 46%. And the ACOS trial, however, was neutral, though it suggested that the prasugrel action is quicker, faster than clopidogrel. Then, if you talk of the kinetics of platelet inhibition over time in a STEMI patient, this is how the prasugrel and ticagrelor show their benefit. As time goes, the action rapidly comes down. So ticagrelor we all use in 2 dosages a day, and prasugrel, however, is a single time. But both seem to decay in their action as time goes, hours go from the onset. Now in STEMI patient, we need a bridging of the gap, time is big essence, and early administration of everything is very important, including quick diagnosis, reaching the hospital, reaching cath lab, getting Dr. Kasturi in the cath lab. All these have their own issues. Then we talk of high loading dose. We also talk of crushing the tablet before we give it. And compared to all this, intravenous administration, I guess, is more reliable and more definitive in terms of dosages that you want to achieve. Now, the molecule today we are talking about, Cangrelor, in the management of CAD is probably the need of the hour. Cangrelor, a novel intravenous agent, is an adenosine triphosphate analog, selectively and reversibly blocks P2Y12 receptor-mediated platelet activation. Cangrelor, administered as IV bolus, followed by continuous infusion, offers rapid and reversible inhibition of platelet function. Now, this is very important. Rapid means it's absolutely rapid. Within 5 minutes, you get a full Cangrelor action. And once you stop, offset these between 30 and 60 minutes. Like patient is on infusion, you are doing a procedure and you realize that you have perforated the coronary and you stop Cangrelor, the action starts going down immediately. And within 30 minutes, the action is completely off. Now, no dose adjustment is required for renal or hepatic impairment. You give a standard dose and the patient will be quite safe. The bioavailability is very high and there is no drug-drug interaction. And thus, whatever patient has received, it doesn't matter. You can continue to use Cangrelor. So when we give Cangrelor, within 5 minutes, you can see a strong platelet inhibition. As long as you continue, you have this infusion showing its effect, and as you stop, the platelet action comes back. So typically, you imagine you have a patient with MI, your onset is on, you also give tablets of antiplatelet orally, and within an hour's time, their action will be on. So IV followed by oral, and the antiplatelet inhibition would be continuous. Mr. Naik, you are going to talk about the dosages.
Yes, sir. Sir, doses of two-way. Sir, one is bolus followed by the infusion. For all the periprocedural MI and primary angioplasty, the bolus would be initiated, followed by the infusion with the bolus is 30 microgram per kg body weight, and then again infusion is 4 microgram per kg per minute. For this therapy, the dosage is 0.75 microgram per kg per hour, sir.
Okay, thank you. I might need your help as we go on again. No?
Yes, sir. Yes, sir.
Then this is a transition to oral therapy. See, we all talk of, we go to the family physician that moment you diagnose or suspect an MI, give 4 tablets of clopidogrel. And now we talk of ticlopidine or prasugrel. However, the actual platelet inhibition, what we achieve, say 85% or above 60%, it takes a while. It takes about 2 hours. You can see here clopidogrel, prasugrel. Ticagrelor is probably the fastest. So, Dr. Sridhar, in your lab, when you are doing a primary angioplasty, what is the tablet that you like to use?
We give aspirin loading dose and ticagrelor loading doses. Suppose for all patients, we are making it mandatory. Only some patients where really long-term cost is less, where we suspect the stent thrombosis is more, and the subset where bifurcation diabetes is there, that time we don't mind giving prasugrel. Particularly when there is no history of stroke, body weight, they are fitting into the criteria. They're high thrombotic. But clopidogrel, frankly, we are not giving as a primary drug. Only in like a thrombolytic therapy or stable ischemic heart disease, some subsets, but the majority of the patients as a primary drug, ticagrelor.
Yeah, actually, this is what we are seeing in most of the cath lab across the country and probably across the world, that if you have an acute MI case, clopidogrel is not on the list. It's either ticagrelor or prasugrel. So this therapy, when to give, that will answer in next few slides. But see, ticagrelor, 180 milligram, that is 2 tablets, during congrural infusion can be given during infusion or immediately after discontinuation of the infusion. However, both clopidogrel and prasugrel, they are given after discontinuation of the congrural infusion. So congrural, when you stop, the action still goes on for about 30 to 60 minutes. And by then, prasugrel and clopidogrel can kick in. While ticagrelor, it's a different kind of molecule, and it can be given at any stage. You can get the patient to casualty, and in casualty itself you can give, and then you can continue with congrural in the cath lab. Now, many times this comparison is bound to happen whenever we talk of intravenous antiplatelets. The congrural, which we are talking today, and the tirofiban kind of molecules. So both have quick onset. They have potent inhibition. I guess congrural has probably 95% or 90% compared to about 85% or 80% of GPI. They both have a reasonably good quick action. But congrural, as I mentioned to you, is on within 5 minutes, while GPI will probably take a little bit longer. In CKD, we can give a standard dose of congrural, and the P2Y12 specific specificity is very strong with cangrelor. So these would be some kind of characters which separate out cangrelor from the other GP inhibitors. So, where are we thinking of using it? We have the US FDA suggestion that as an adjunct to PCI for reducing the risk of periprocedural MI, repeated coronary revascularization, and stent thrombosis in patients not treated with P2Y12 inhibitors earlier. So I think these are very important indications. I think I generally like to talk to my referring family physicians, and they are very up to date, and they would probably, they're already giving ticagrelor 2 tablets instead of clopidogrel. So I would feel these are some few things which we must remember. The European Society cangrelor may be considered in P2Y12 receptor inhibitor NAV patients undergoing PCI. So patient has not received and then you want to give something. I think this is a very important molecule. So what is the data or the clinical evidence that we have? And these are 3 important studies. They are slightly different from each other, but the name is common, the Champion Phoenix, Champion Platform, and Champion PCI. The important thing to remember that there was no excess in the gusto, severe or moderate bleeding by using cangrelor. So most of the time when we use more effective or stronger inhibitory drugs, we are worried about bleeding. But there was no increase in bleeding with cangrelor as a molecule. Now we have these important trials, Champion Phoenix, Champion PCI, and Champion Platform. The all have this cangrelor bolus given, and you heard the dose just now. And then there is an infusion, and the clopidogrel, it was either 600 or 300 milligram in Champion Phoenix. In Champion PCI, it was 600 milligram. And even in Platform, it was 600 milligrams. And then these were continued after at the end of your procedure. And these Phoenix, Champion Phoenix, actually indicated a good comparison between cangrelor versus clopidogrel. And overall, if you see the event rates, stent thrombosis, death MI, IDR, QA MI, they are clearly less, though statistically, this part looks very important, death MI and IDR. Now, this is again a landmark analysis of the Phoenix study. At the end of 2 hours, these patients' cangrelor infusion was stopped and they received clopidogrel. And you can see the result, 0.6 and 0.7. So not much of difference later. Stent thrombosis was clearly less when you continue cangrelor compared to just clopidogrel. And death, MI, IDR, and stent thrombosis within 48 hours was clearly less with cangrelor. I'm sorry, the background is also red and the line is also red, but it is much less compared to clopidogrel when you follow them for next 2 days. Then you have this death, MI, IDR, and stent thrombosis. Again, cangrelor looks much better compared to clopidogrel. At end of 48 hours, death, MI, IDR, or stent thrombosis. Again, cangrelor looks better. And this is under different subset. The dosages of clopidogrel, whether you use bivalirudin or heparin, and whether you use different kind of stents, drug-eluting, dose of aspirin, and under all these, cangrelor seems to fare better compared to clopidogrel alone. In this champion meta-analysis, you find efficacy outcomes at the end of 48 hours, and you find that cangrelor had clearly improved results compared to plain clopidogrel. Same in this, that cangrelor is a favored drug against competitors. Then, when you talk of these 3 studies, the Phoenix probably is giving a more robust kind of benefit with cangrelor. And you can see here that Phoenix had much stronger benefits seen. The intraprocedural stent thrombosis, again, really better with, improved results with cangrelor compared to others. You can see again a 30-day mortality, cangrelor and clopidogrel, big difference. So the stent thrombosis is something which we worry about. And you can see intraprocedural stent thrombosis is clearly brought down surely and significantly by cangrelor compared to clopidogrel. Now, this is again intraprocedural stent thrombosis, almost 11,000 cases. And this is a reduction shown by cangrelor. You can see red is cangrelor compared to blue clopidogrel. And you can see cangrelor giving you benefit on ST elevation MI, non-ST elevation MI, stable angina, and in general, all cases. So there is every reason that we should think of this kind of molecule for different indications. Then we have this champion Phoenix data, intraprocedural stent thrombosis, clearly far less with cangrelor compared to clopidogrel. And this holds true for almost a month, that you have a lesser reduction, a lesser number of stent thrombosis compared to plain clopidogrel. So these are the main studies, Champion Phoenix, Champion Platform, and Champion PCI. I think the US FDA was not very convinced with these 2009 and 2009 studies. But 2013, a slightly differently designed Champion Phoenix study was able to get US FDA sanction. And as I mentioned, there is a big number of usage across the entire United States for this molecule. Now, there are these other studies, the Cantic trial. They use these crush Trachegalor 2 tablets in both the arms, one with Cangrelor and one without Cangrelor. And you can see there was a clear benefit when we give Cangrelor with crushed Trachegal. So Cantic study actually indicated that Trachegalor can be administered as a crushed formulation concomitantly with Cangrelor without any apparent drug-drug interaction. See, we saw for both clopidogrel as well as prasugrel, there was some kind of drug-drug interaction, but Trachegalor had no such issue, and we can safely use these. Then this is another evaluation of GPI during PCI, comparing with Cangrelor. And all these bleeding events, clinical outcomes at 30 days in hospital length of stay and intensive care length of stay, all were definitely benefited with Cangrelor. In hospital bleeding events such as major bleeding, transfusion, vascular complication was significantly lower in Cangrelor. I think this is what we worry about, the vascular complication, though major bleeding and anything requiring transfusion is probably sort of unheard of in my cath lab. Then these can be also used as a bridge for a possible surgery. Like patient has a stent placed today and he needs an emergency surgery 10 days from now. Prior to surgery, you can use these intravenous, stop appropriate time before surgery, depending on what kind of surgery you're doing. And you would find that it acts very well for bridge to surgery. So those patients who are very hot, like getting recurrent angina, repeated ST changes, as they're waiting for bypass surgery, they can be given this kind of molecule to cool down the intensity of the situation. Now, this is again PRU of less than 240 for with Cangrelor, very important compared to, let's say, Mr. Naik or Abhijit, one of you want to comment on this slide?
Yes, sir. Sir, there were 104 patients which was enrolled for Cangrelor, and for placebo it was 86. So the bridge therapy, what it shows that like Cangrelor can be given minimum of 2 days and maximum for the 7 days. And PRU level was it was 240, which is achieved in the Cangrelor level, sir, for this Cangrelor.
Okay, so Cangrelor can be used prior to the surgery.
Yes.
Sridhar, you have any comments on this?
Yeah, what is the infusion rate you are maintaining for, suppose if you are giving for 5 days, is it a 4 micrograms only?
No, sir, it's 0.75 micrograms, sir.
0.7, no loading
Yes.
dose.
No loading dose, sir. Only infusion, and it will be given as a 0.75.
But in some study, they are giving only for 2 days prior to the surgery. Stop clopidogrel or any antiplatelet, stop like a 5 to 7 days prior to surgery, stop and you restart the cannular infusion 2 days prior also. They are recommending. Can
Yes.
you comment on that?
Sir, again, sir, it depends on, sir, antiplatelet. If the as we all are aware, sir, we are stopping ticagrelol like 3 to 5 days before. So from there onwards, but for prasugrel and clopidogrel, it is 5 to 7 days. So depending on the, sir, antiplatelet, like when we are stopping. For ticagrelol, it is like 3 days also, sir, we can start off, sir.
What rationale they are saying, like once you stop, it will have some action for another 2-3 days, at least 48 hours prior to surgery. You start with the support to reduce the cost. 2 days prior to the surgery, start, and 6 hours prior you can stop.
Yes, sir.
Basic difference between all these three, as you know, that the basic nature of these three antiplatelets, prasugrel and clopidogrel, remains to that particular class where it is irreversible in nature. While if you see that this ticagrelol and cangrelor both are reversible in nature. So once we are stopping this thing, after 2 days itself, we can start this cangrelor for some duration of time, as long as the surgery is delayed.
No, we are not saying about that, because the recommendations are prasugrel 7 days prior you stop, but clopidogrel or ticagrelor, if you want, you can 5 days prior you can stop.
Correct, sir.
But even another 2 days after stopping, whatever the existing drug in the body will have some antiplatelet activity. So either you can start immediately antiplatelet activity. Suppose the patient is not very high risk group, you can skip for 2-3 days antiplatelet and 2 days prior to the start surgery. That means you are stopping 5 days before surgery. You can start on 3rd or 4th day, continue for 2 days, and just before surgery you can stop. That is the strategy they are adapting.
So, Sridhar, can I summarize? Like,
yes,
surgery
yes,
is on Friday.
Yeah.
Sridhar's angioplasty patient, let's say 2 weeks back, he's at an important location angioplasty. So you stop oral antiplatelets on Monday, Friday and Monday. Monday before Friday, 5 days. And Monday, Tuesday, Wednesday, you stop. And probably Wednesday afternoon to Thursday evening, you give cangrelor, and Friday you operate on this patient. Is that correct?
Yeah, yes, sir.
I'm just generalizing so that smaller people, mortals like us, can understand from you, Sridhar. So you stop your oral antiplatelet therapy. Whatever you stop, they would be effective for next 2 or 3 days. So your stent is safe, and just 2 days prior to the actual surgery, give cangrelor for about 24 to 36 hours. So this is the bridge therapy, cangrelor versus placebo. It can be used in pre-CABG also, like you do a hot case, patient getting severe angina, multiple ST depression, coming, going, and then you use cangrelor, you stop it, say, before surgery, and you would be able to go through bypass surgery too. So to summarize, when used as a bridging strategy for CABG after the thiopyridine discontinuation, cangrelor, see the dose, it is different, and it was mentioned to you, 0.75, not 4 milligram per kg per minute achieves levels of platelet inhibition known to be associated with low risk of thrombotic events. I think this is a special dose which more than cardiologists, the anesthesiologists should remember. And this is without increased risk of bleeding before or during CABG, although with a numerical increase in the minor pre-CABG bleeding, independent of prior thiopyridine dose and time of discontinuation. This is, I don't know how to explain. Sridhar, can you explain? why it should be independent of thiopidine dose or discontinuation.
Independent of prior thiopidine dose.
Yeah, I mean, whatever we talk about clopidogrel 5 days, prasugrel 7 days, I think that still holds true according to me. Anyway, this would cover up the intermediate portion where patient is very hot and getting angina again and again. Consistent pharmacodynamics effects during IV infusion. That this is extremely appreciative when you use Congrelor. We used it for 100 cases, and none of them had a problem during our analysis. The rapid offset after IV discontinuation, this is also prior to surgery, of course, is a very important thing. But the more important usage is when you run into trouble like perforation of a vessel, the rapid discontinuation really is a very important. No increased incidence of adverse event like dyspnea that you get with some others, and lab abnormalities despite extended dosing. And the results of bridge trials support the hypothesis that IV Congrelor is feasible and safe management strategy in patients who require prolonged platelet P2Y12 inhibition after thiopidine discontinuation prior to cardiac surgery, I guess, for others also. Sridhar, I'm going to stop here.
Okay.
And let's hear from you.
Yeah, okay.
So maybe just one little time. Who benefits most with this therapy? The ACS paired from preloaded DAPT. So if patient is not preloaded, I think you can give IV Congrelor. The onset is immediate and offset is also very quick. So either ways, you're pretty good. So don't forget to reload your oral antiplatelet therapy towards the end of this procedure. Sridhar, suppose you are stopping at 1 o'clock in the afternoon, exactly 1 o'clock, the Congrelor injection. When would you give your clopidogrel and ticagrelor and prasugrel?
Actually, ticagrelor you can start at the time of beginning of infusion, during or at the end, but only clopidogrel and prasugrel should be given at the time of termination of infusion. So that is the recommendation.
I think this is something new. I mean, we are used to sort of pushing tablets down some patient's throat. The moment we diagnose ACS or MI. So for this particular molecule, I think we need to deviate a bit. Patients going for CABG and non-cardiac surgeries, they would also benefit, reduce the cost and need for GP2B3A blockers. This would be a major concern if patient is going for surgery soon. Benefit is sustained for 30 days. Intuitive in chip cases like left main bifurcation, long multiple stents, overlapping stents, and bridging surgery. And sick ICU where eternal medicines withhold. And timing of clopidogrel, ticagrelor, this we discussed. As Sridhar said, ticagrelor can be given anytime prior to, during, or immediately at the end of the procedure. But clopidogrel at the end of the procedure. And bivalirudin Congrelor is a wonderful combination. I think bivalirudin in India has not picked up very strongly, but I guess in US, Sridhar, you're aware if they use these two in US in most of the labs?
I'm not that much aware, sir, but we used bivalirudin for almost 150 cases, but somehow these patients were requiring more of glycoprotein to be because the thrombosis, catheter thrombosis, one of the concern for that one. And that's the reason I think Congrelor combination reduces the more platelet activity, I think.
Okay, I will stop here, and Sridhar, over to you.
Yes. I think you stop sharing. Able to see, sir?
Yes,
Yes.
sir. It is visible, sir.
Yeah, good evening. Thank you very much for inviting me as a faculty. It is always a pleasure, and I'm privileged to share DAS with online DAS with Dr. Shirish Heramat. We always look up to him, and is one of the very well-known, renowned person who does very complex PC and always motivates youngsters like me. I'm not too young, although I'm reaching 60. But so, I mean, some of the slides are repetition, but I will not go in detail because he made my life easier and more comfortable, narrated very nicely, beautifully. And I will try to rationalize how we are going to use this product in a day-to-day practice. So it's a parenteral, as sir mentioned very clearly, the half-life is only 3 to 6 minutes. The offset is only 60 minutes, and this is independent. This hepatic dysfunction and renal function will not affect its metabolism. The most important benefit is decrease in stent thrombosis and MI in all patients undergoing PCI. So usefully in all those who have administrative problems, the lack of, suppose if your patient is unable to swallow because of the vomiting or difficulty in absorption because of the hypertension, and at the same time, when not loaded with prior antiplatelet agents, you are doing angiogram. After that, you suspect severe disease, that patient may go for CABG. That time you can give a cangrelor, and after that you can stop and you can send for surgery. That is also another reputable. So as you are aware, this is mainly recommended for PCN patients with and without ACS. But if you see the prasugrel and ticagrelor mainly for ACA, and the history of STEMI for ticagrelor, this is for ACS. And caprolactam you can give for ACS or stabilis ischemic peripheral arterial. Already this is highlighted. I will try to skip. This is a very important slide which showed definite reduction in stent thrombosis during first 48 hours compared to the clopidogrel group. And whenever you see any patient undergoing PCI, so how to start? First, you start the infusion, already not loaded with the antiplatelets, came to emergency like a STEMI patient or high-risk ACS patient. Start with the cangrelor. And if you are if you are loading him with the ticagrelor, you can start at the beginning of infusion or during or at the end of the infusion. But if you want to give a clopidogrel and prasugrel, these should be given. Usually, we have to give the infusion for 2 hours. But if the procedure is very complex, prolonged, more than 2 or 3 hours, you have to continue the infusion until the procedure over, like a 3 or 4 hours. And at the end of termination of the procedure, you can load the dose with, you give a loading dose of clopidogrel or prasugrel. And suppose if the patient came to emergency, assume that you are in a tertiary care, you are doing the primary PCI or angiogram.
Can I ask you a question, Sridhar?
Yes, sir.
Many patients are treated close by, say, 50 miles away from my hospital.
Yes.
And they are loaded with clopidogrel along with the lytic therapy.
Yeah.
So that is their primary treatment that they do very well. So if patient has received clopidogrel, what is the dose, or do you make any variation?
No, actually, now as of recommendations, clopidogrel and prasugrel interferes with the mechanism of action. That's the reason you have to really high risk subset is there. You can do the dose. Otherwise, this is mainly for patients who are not receiving the TAP therapy, not loaded with no thrombolytic therapy. In such patients are only they have recommended. So assume the patient has come to emergency. You decide whether the patient comes under very high risk subset or low risk subset. Is it STEMI or you see the ECG? Is it normal ECG? Suppose TROP-I not elevated, no rapid rise is there. This comes under low risk. Everybody is aware of that. But ST elevation, ST depression, markedly rising TROP-I, definitely this comes under high risk subset of ACS or STEMI patients. So always check whether is there any delay in viability of the drug, or patient is in cardiogenic shock, or if the patient is under heavy sedation, or any morphine use is there, or mechanically ventilated, or if the patient is vomiting, particularly more so with infravoluntary posterior strokes, where they have a recurrent vomiting. In such cases, oral drugs will not be effective. Even if you go, that dose will be very, very low dose. And a Cangrelor, that time you start the Cangrelor bolus infusion and then continue the procedure. And at the end of the procedure, you can give the clopidogrel or you can give the prasugrel. But there is no restriction for this like a ticagrelor, you can give at the time of beginning. But other drugs, why it's not recommended? Suppose preloaded. That means if there is a gap of like 6 hours, already that patient may be having adequate therapeutic levels of the platelet activity, antiplatelet activity. So that time there is no need to add. It may lead to bleeding complications. But within 1 hour, if they are coming, still the therapeutic levels are not adequate. That time you can start the infusion. So you see that what is the gap when he's reaching from the peripheral hospital to the center? Is it 1 hour, half an hour, or 2 hours, 3 hours? Based upon that, you can take a decision. And I will show a few cases examples how we can think of the antiplatelet strategy. This is a 69-year-old male, non-hypertensive, presented with complaints of chest pain, also with shortness of breath, with profuse sweating, acute inferior wall MI, RVMI with cardiogenic shock. So ST elevation in inferior leads as well as the V4 leads, mild elbow dysfunction. If you see the TROP-I markedly elevated, more than 26,678. So inferior wall MI, hypotension, and markedly elevated TROP-I. So pressure is only 60 pressure. This is the ECG. You can see ST elevation in inferior leads, and there is a ST elevation in right-sided lead also. And then patient was loaded with aspirin, IV fluids, dopadopitamine, ticagrelor was given, loading dose, atorvastatin loading dose, and then we started a Cangrelor infusion and shifted to cath lab for primary PCA. So when you go through this chart, this patient already hypertension was there, markedly elevated, TROP-I is there, ST elevation is there, and if you see the cardiogenic shock and patient is not on ventilator, but history of vomiting was there. So definitely start the Cangrelor infusion. Suppose if you only load with the drugs, when you take him, because the hypertension, poor absorption, so you may not have a better bioavailability of the antiplatelet drugs, and chance of stent thrombosis very high. So that was reflected in our Champion Phoenix study. So that's the reason we started a Cangrelor infusion with the ticagrelor combination. So this is the one where how to start like a 30 micrograms per kg bolus and 4 micrograms. This should be continued for 2 hours. But if the procedure is very complex, prolonged, sometimes many times it's every cardiologist experience, sometimes procedure may go to 3 to 4 hours. In such cases, don't stop, you continue the infusion until the procedure is over. At the end of the procedure, you load with the clopidogrel or prasugrel. But ticagrelor, no such restriction, you can start at any time. And this is the angiogram. You can see the LED is fine and the LCX is fine. Right coronary proximally total accorded. This is a dominant right coronary. And this is the beginning pressure. You can see the 67/45 pressure before and post procedure. This is the right coronary. Then we crossed with the wire. Just I'm showing the example. So this is we stented with a 3 into 35 mm Zions expedition. Right coronary was stented. So I will show one case at the end. Suppose if this infusion is not there, sometimes the chance of sudden occlusion, no flow, slow flow is very high. So the other option, we can give a glycoprotein 2B3A, but as Dr. Shirish Hermes sir already highlighted, the bleeding complications are more with. Moreover, these drugs are becoming extinct because many drugs are not available like abscissaril is available, some tirofiban is available, iptefibid almost extinct from the market. So I think in such cases, the bleeding complication is much lower with the cangrelular infusion. So ideal to start cangrelular infusion to avoid the stent thrombosis. This is another 47-year-old male patient present with epigastric pain, radiating with the chest pain, associated with the vomitings and profuse sweating, ongoing chest pain, and recently a patient suffered from COVID. So acute atrial MI, QRBB, cardiogenic shock, and when he came, he was conscious and he was profusely sweating. And that time we were trying to ship the patient loaded with ticagrelor and aspirin. Suddenly developed cardiac arrest, and CPR was done, intubated, and shifted to cath lab for emergency PCI. And you can see that troponin is markedly elevated, 26,000, and NT-proBNP is also significantly. There is a significant LV dysfunction, and fortunately renal dysfunction was not there, and pressure is very low. You can see the QRBB very clearly, QRBB ST elevation, and as while shifting started with a loading dose of aspirin, and ticagrelor was given, dopamine, dobutamine, and was given, statin loading dose was given, cangrelular infusion was started, shifted to cath lab. So here also, if you see this patient subset, the patient came with MI, and you can high risk subset because the shock was there, ST elevation was there, markedly elevated troponin was there, and rising trend was there. And here STEMI, and the patient was intubated, cardiogenic shock. And in this subset, definitely these subset of patients, it is extremely useful because low pressures and the patient is on intubation. Many times the poor bioavailability of oral medications, many times you may not achieve the therapeutic effect. So this is the study where it has shown in STEMI patients, the regular DAPT therapy has very slow onset of action. See, if you see at the end of 2 hours of the DAPT loading dose, like a conventional loading dose, you can say only 48% will have a therapeutic effect, only 48%, even at the end of 2 hours. Many times within 1 hour, we are going to finish the case. And by the time you get the effect, it will take 6 hours, 6 to 24 hours, you get the full therapeutic effect. So that's the reason always these patients require adequate antiplatelet therapy during the first 2 hours. That is very important. The ticagrelor versus this is a rapid primary PCA study where you see first 2 hours, the almost only very negligible. So 50% of the patient will not have an effective antiplatelet activity with standard DAPT therapy. So to get the at least reasonable effect, it takes 6 hours. So this is the MI. You can see the ST elevation, QRBB, acute obstruction of the LAD. And we crossed just by passing the wire with daughtering. Then we got the flow. LAD was stented immediately. So this is post-dilatation with a 3.5, and this is the final result. So this is a rare subset of acute MI, on ventilator, cardiogenic shock, episodes of VTVF. In such cases, you want the rapid antiplatelet activity, which cannot be achieved, the therapeutic effect will not be achieved with a regular DAPT therapy. In such case, IV infusion, where the onset of action within 2 to 3 minutes, that is very offset. If you stop within 1 hour, the action is going to be off. That is very important. This is another 56-year-old male, non-diabetic, present with the complaints of syncope, associated with vomitings and profuse sweating, antival MI. You can see that here also there is a troponin significantly elevated, creatinine normal, and pulse rate was 106, and pressure was 90, low pressure. You can see the extensive antival MI. Here, if you see the ECG, left main is also diseased, medullary tight lesion, and OM is closed. And you can see the right coronary diffuse disease, right coronary, proximal to mid, and distally another tight lesion was there. Here, this patient came under scheme, so our intention is to at least to do the culprit and get him out of the crisis period. And after that, we gave a infusion of cangrelular infusion. Then we did emergency. You see the ostial left main lesion was there. Because reflux was there, pressure not that tampering is there. We were not sure, is it because of the reverse coning effect or whatever it may be. So we wanted to see, is it physiological narrowing of the ostium or because So that time we did the emergency because there was no hazing of the left main ostium. Then emergency LMCS stenting was done, LED stenting was done. Then after that, post dilatation, patient became stable. So what we thought, we'll give a gap of 1 month because he's under scheme. The permission will not be there for imaging and everything, at least to bring him out of the crisis. LED stenting was done. Now what to do after this? Okay, 1 month later, or you want to send for surgery. In such case, okay, assume that patient is having a recurrent angina, is not recovering. That time, you can stop the DAPT if you are planning for surgery. You can stop the DAPT and you can go with the cannular infusion, maintain for 3-4 days. And if the surgeon is comfortable, well, like a 4th day or 5th day, you can plan for surgery. Otherwise, you give a gap and continue the antiplatelet agents and reassess 1 month later if the patient is asymptomatic. Do the FFR study of the left main, and that time you can give the on clopidogrel because of the limitations. Go with a good, and the patient is not taking adequate antiplatelet therapy, only SAPTA is there. That time you can give the cannular infusion. So based upon when he's coming for the procedure, easy off the medications, easy on SAP therapy, easy on full loading dose. Based upon that, you can take the appropriate decision. This is an 85-year-old gentleman, is a practicing ophthalmologist, non-diabetic, hypertensive. He has been suffering from symptoms for the past 1 week, but one day he came to Hyderabad, actually belonged to Tirupati. When he came to attend one of his family members' marriage, that time, an evening, suddenly became breathless and severe orthopneic and then shifted to hospital. He was intubated, blood pressure was 60 and palpitations and hypotension, gradual worsening of SOB. So a patient came with elevated JVP, bilateral pedal edema, then we intubated. Then we thought ECG was showing AVR elevation. You can see AVR ST elevation. So then we told them very clearly, most likely left main may be there, 84-year-old previous PCI to LED was there. Then we did angiogram. That time when we did angiogram, actually morning he is self-extubated. After self-extubation, then we counseled everything. We took him for, that time we told there is a need for MCS like a Impella. We were counseling. Then after that, we did angiogram. We shifted to post-cath. After shifting to post-cath, patient suddenly became apneic again. We intubated, then we shifted to cath lab. We put him on IABP. Then CPR was done. Then this patient comes under very high risk because ST elevation and very high risk group, IABP. Then we counsel for, you can see the LMC, a very, very tight lesion, and LCX, very sluggish flow, LED slow flow phenomena is there. It's a very sluggish flow. Fortunately, this comes under altoma, acute left main total occlusion. And these patients usually they will have right coronary support. Otherwise, they don't make it. This already Dr. Shri Sahiramat sir mentioned, 64% of these TB patients with cardiac arrest are unconscious during evaluation. Many times what happened, these patients, because of the these high-risk subset patients may be intubated cardiogenic shock patients. So in cardiogenic shock, there is a one study that where they treated with the cannular in 38 patients. The 1 year mortality was 13%, stent thrombosis was 0, and gastro bleeding severe was 0, and mild to moderate was seen in 29%, and the intracranial, this is very safe. So cardiogenic shock patients, particularly where you want better antiplatelet activity, this is the preferred drug to make a more effective antiplatelet activity, because many times poor absorption of these drugs because of the hypertension. So then this is a chip left main stenting with the Impella support with IVL and IVAS. So this is the left main. We put him on Impella, and then we crossed, then we did the DK cross stenting of the left main with the IVL, and patient tolerated very well, absolutely very well. So this is the subset where you can use these type of drugs. This is another patient. I think this is the last patient, 33-year-old male, treated with thrombotherapy and came with a chest pain, ongoing chest pain. A patient had interval MI. That time, patient with regional, he is an agriculturist. So his finances were not that much. He belongs to like a scheme. So then you can see the marked ST elevation, and post thrombotherapy, failed thrombolysis, ST elevation, persistent ST elevation. you can see there is a tight stenosis. And then what we thought, then because he's agriculturist, he's a very young man, hardly 32-year-old, then what we thought will help him. So we did a DK crust stenting of the LAD and LCX with a regular standard DAP therapy, and patient was doing well. But 1 month later, he stopped medications. So you see, suddenly stopped. This that you can see the DK crust stenting. Absolutely beautiful result. Kissing, everything was done. I thought of, I took the help of the company, wanted to stent, help him because of the finances and agriculturist. See, post PC, absolutely he became fine. But 10 days later, because he belongs to periphery, there he was not getting that ticagrelor. So that brand was not available. The pharmacist was not aware. Then he said, due to lack of availability, he did not know. I told him, why did you call us? But suddenly he developed chest pain 10 days later. And you see the ECG, you can see the MI, acute MI, stent thrombosis. How to treat these type of patients? When they come to hospital in emergency due to lack of drugs, the best drug is aspirin and start the IV cangrelor infusion. And if you want, you can give the loading dose of the ticagrelor, but cangrelor is the drug of choice for these type of patients. You start the procedure. Because he belongs to the like a scheme, we can't do another PCA for that patient because the finances permission, will not permit. And stent thrombus, always I tend to use the imaging to see what could be, but 99% is because of the stoppage of the DAP therapy. Then we subject him for surgery. When you are sending for surgery also, you can start the cangrelor infusion and continue until the surgery day. And just before surgery, you can stop 1 hour prior. The offset of action, 1 hour, that is very important. So the surgical, already Dr. Shri Sairana sir highlighted, even with his pre-surgical cangrelor infusion, there is significant reduction in the event rate. That is a very important point. So this is already highlighted. I don't want to stress again this point again. This is a 63-year-old male, non-diabetic, hypertensive, present with SOB, cardiogenic shock. And you see here, the left main, the patient came to hospital in the morning hours. Recurrent VTVF, pressure was low, 60 millimeters of mercury, and then intubated. And you see the right coronary, middle and distal, mid and distal lesion is there. LMC, a very, very tight critical lesion. Then these patients are the ideal candidate for cangrelor infusion. That time we didn't have a cangrelor infusion. We shifted to an emergency basis, intubated, shifted, inotropics were given. You see the right coronary, proximal and mid was stented. Then our intention is to do the right coronary, then go to the left main. We gave a bolus of the glycoprotein 2B, but unfortunately, immediately after right coronary, then we withdrew the catheter. We were moving to the left main coronary, but suddenly developed cardiac arrest, and he could not revive despite re-engaging and retrying, because left main was so critical in such cases, because the poor bioavailability of the antiplatelet therapy. In such cases, definitely cangrelor will make the difference. I think when the patient is on intubation or hypotension or vomiting or poor bioavailability is there, in such cases, definitely, at least we can save some patients. I think this is a natural medicine. It is going to have an immense role, because if you see the Champion Phoenix trial, the clopidogrel versus cangrelor, the MACE rate reduction is significant. And if you see the stent thrombosis, those patients who are developing intraprocedural stent thrombosis, the impact on 30-day mortality, if you see, if they develop IPST, the with and without, you see almost 10 times more. The mortality is 10 times more when they develop the IPST. That's a very important factor. So this was highlighted again, because compared to glycoprotein 2B 3 years, the combination of the cangrelor is definitely superior, particularly in terms of reduction in the MACE related to the bleeding. There is significant reduction in the bleeding. And
there is a question in the chat question box.
Yes, sir.
Whether you would use when would you use these two, cangrelor plus GP blocker?
No, when we use this drug, I think there is no need of, because the bioavailability is very good, action is within no resistance. There's no need to use additional glycoprotein 2b3 blockers, because only they have tried glycoprotein 2b in addition to the clopidogrel and other drugs. Even meta-analysis, whatever the meta-analysis were earlier studies, that is when the clopidogrel was in limelight. Now we are using only for add-on, particularly when the slow flow is there, no flow is there. But these, the ticagrelor and prasugrel so effective, it will not make any difference when you add this one. But because the why it makes difference means the first 2 hours, the bioavailability is not there during emergency setting. That time, because the rapid onset of action, that is going to play a game changer role. Even suppose you have given loading doses, patient came 2 hours later, that time 2 hours or 3 hours later, that time combination of cangrelor is not going to help unless some clopidogrel patient with clopidogrel resistance is there. But it will not make any difference when the patient is having the prasugrel or patient is taking, because the rationale of the champion Phoenix also, that the first 2 hours, the effect of the drugs, oral drugs is almost 40%, because that it made a difference. So I think that's the reason. Because another thing is glycoprotein 2b, once you give, it acts on the glycoprotein 2b receptor, that is going to stay until the platelet lifespan. The action is longer. You can't stop right, you're sending for surgery, bleeding complications are more. And again, already you highlighted, sir, that like a renal, hepatic, also function also makes a difference. That's the reason I think the rationale, if we understand, mainly the first 2 hours of period, very crucial during PCI. That time, what we need, the best antiplatelet agent, which can produce the best antiplatelet activity. Other drugs are also very good, but problem is because the bioavailability is less, because they have to go through the gut. So it takes time. So at least it takes 2 or 3 hours time. So in emergency, it is that time will not be permitted, particularly when the hypertension is there, particularly when the patient is angry, high risk subset, left main, multiple stenting, long stenting is there. Such patients definitely requires this type of drug, because already you see it is useful. It's scored over the clopidogrel in all subset patients, irrespective of age, irrespective of gender, ethnicity, and whether stable. This also proved beneficial in stable and unstable and STEMI patients also, irrespective of weight. So it proved superior in all subset of patients. And the bleeding is not very high compared to the clopidogrel. Very severe bleeding, almost equal. So negligible, non-significant increase in bleeding, particularly only mild to moderate. But Cantic study already highlighted, even with the chewing, like a chewed ticagrelor also will not produce effective antiplatelet activity during the first 2 hours. So for that sake, the cangrelor definitely makes the difference. This was proven in a Cantic study. So I think the platelet activity, first 2 hours plays a very crucial role, and during first hours, because within 2 minutes you are going to get the good effective antiplatelet activity. That is what we need, particularly when you are taking a cardiogenic patients with a high risk subset of patients. These are various trials which have shown beyond doubt the efficacy of these drugs. And to summarize, when the patient comes with high risk ACS or STEMI patients, you just see patient belongs to low risk, poor low risk, like a normal ECG, tropi normal, and these patients may not require. When patient comes under moderate or severe risk, particularly when the elevated tropi or raising tropi and hemodynamic imbalance is there, ST elevation or deep ST depression is there, and particularly those who are very high risk subset, when they were not preloaded with DAP therapy, particularly highly potent drugs like a prasugrel or ticagrelor, and where you expect the poor bioavailability because of the vomiting or cardiogenic shock, or patients on heavy sedation and morphine, mechanical ventilation, these patients, this is the drug of choice. And I think this is going to make a difference, and it's a game changer. Definitely more and more hospitals are going to adopt this policy. Thank you. Thank you very much, sir. Thank you for paying attention.
Thank you indeed. I mean, that was really taking us through what we do on day-to-day basis. Can I ask you one sort of story question?
Yes, sir.
Like, we have a 50-year-old in the casualty, less than 1 hour of very intense chest pain. ECG showing anterior MI, right bundle branch block, left post anterior MI block. And blood pressure is borderline, say 85, 80, and so on. So what are the steps that you take? He's in the casualty and you are informed in the cath lab.
No, I would insist them to start the cannular infusion in the casualty itself. By the time he comes, even if you can start in the cath lab, but at the same time, we will ask them to start. If that time we will continue the infusion. Many times, primary PCI, it's very easy to cross. Many times we complete within half an hour. Maximum 1 hour procedure can be done. Most of the time, softly, unless extremely old patients where calcified lesions, we expect a longer time. But that is a minority of patients. But majority, most of the time, the results are very quicker. So that time, I will ask them to load with the aspirin. I will also ask them to take the ticagrelor loading dose, because by the time we finish the drug, there is no interaction, that a therapeutic effect will be there. We can start the cannular infusion anterior LMI, because LAD is a very important vessel. It's a definitely life-saving vessel. It has to be monitored and it has to be very careful. Suddenly the patient may collapse. And once you put the stent also, because of the lack of antiplatelet drug therapeutic effect, we should not lose the patient. Though it may be a small number, that small number also very important.
But you know, the drug has not even reached many cath labs. And you're housing the drug in the casualty. Isn't that a bit too much?
No, but now I think now they are making it available. I think that strategy we should adapt. I think particularly high-risk subset as anterior MI or cardiogenic shock, at least ventilated patient, those who are high-risk hemodynamic imbalance patients. That also no need to give, but at the time of shifting, they can start the bolus and they can start and shift to the cath lab. By that time, will be very, very comfortable. We start.
Since the action is on in 5 minutes time.
Yeah, in 5 minutes. Even cath lab also we can start, but sometimes cardiogenic shock patients, at least because that platelet activity, at least that medically it can
start dissolving the clot.
Yes.
It can start dissolving the clot.
Start dissolve.
And then you are radial or groin for this kind of case?
So 90% radial only, but only like once we do the radial, really complex calcified is there, we can switch on to the nowadays, because the slender sheath is there now. Many complex bifurcation rota can be done through the radial, but majority of the cases transradial bleeding complications are very low, and even chip subsets also, they've shown very clearly those patients underwent ECMO and those patients underwent Impel also. The bleeding complications are particularly major access site bleeding complications are very low with this infusion compared to glycoprotective B3.
So this vial of Cangrelor is how much? It's 40 ml or?
This is 50 mg, sir.
50?
mg, 50 milligram. So one vial is quite sufficient for one patient less than 100 kg, sir, for any PCI cases.
So if you have bolus from a
bolus 30 micrograms per kg and 40 micrograms per kg per minute, we have to continue for 2 hours. But procedure is prolonged. We have to take one more vial and we have to continue the infusion. That is over.
And what if patient has received thrombolytic therapy?
Thrombolytic therapy should not be recommended.
No. Patient has received thrombolytic therapy, say 2 hours from your hospital. And after receiving thrombolytic therapy, after about 6-8 hours, the patient is with you. Is it okay to use this, or you would use conventional heparin?
I will use like more than 6 hours or 12 hours. That time I am comfortable, but immediately after receiving therapy, it's not recommended.
And you know, these patients who are transferred like this, all right, you decide to wait and do it next morning. But patient has received antiplatelet orally. Maybe he has received ticagrelor or clopidogrel. Is it okay to use Congrular next day morning in the cath lab?
Sir, after 2 hours later, if they are coming with the loading doses, frankly, because the therapeutic effect will be achieving after 6 hours. In such cases, I feel there is no added benefit. Because those who are not preloaded or those who are reaching within 1 hour, that time the therapeutic effect is not there. Definitely, it's going to add benefit.
No.
Patients,
I'm asking you in a different fashion.
Yeah.
Say Sunday afternoon, patient is lysed.
Yeah.
50 miles from your center, and patient is transferred to you on Sunday evening and is stable. The thrombolytic has been quite effective based on the ECG. So you would take him up next morning, right?
Yep.
And patient has received clopidogrel or maybe even ticagrelor the previous day along with thrombolytic therapy. Who is on low molecular weight heparin, he's on oral antiplatelet, and he's in the cath lab, and you want to do an angioplasty. So is it okay to use this intravenous?
And my opinion, because the Champion Phoenix trial, mainly the bioavailability, the drug therapeutic levels are not adequate within 2 hours. So that's the reason. But if already preloaded with the drugs, taking adequate DAP therapy many times, if clopidogrel is different, but when they are taking ticagrelor, there is no added benefit. Otherwise, you can stop and you can ticagrelor additionally we can do. But even without that, also we will have a adequate antiplatelet activity because when they have taken adequate doses with 6 hours prior.
Somebody can check, Nitin, or can you tell somebody if there are any questions in the chat box?
Yes, sir. I will take it. In fact, one of the question is, sir, that how do you see that in future can it take the place of GP2B3 inhibitors, Cangrelor?
Yeah, definitely. Now the glycoprotein 2B blockers, almost now the many studies have not shown any beneficial and bleeding complications are there at the same time that liver function and renal functional metabolism also makes a difference. But this is mainly, as I mentioned, this is a drug which is going to have a rapid onset, rapid upset. That is making difference. Onset of action rapid. Within 2 to 3 minutes you are getting. And at the same time, once you stop within 1 hour, the effect is gone. But the glycoprotein 2B, the effect is not, it's a continuous. As long as the platelets are there, it's substituted by the new platelet. That action is going to last for longer time. So that's the reason this drug is definitely is going to replace and it will make a rapid gain in momentum, definitely. It gains a lot of early momentum.
One of the questions is there, sir, that how do you see the uses of Cangrelor as a intracoronary uses?
I think we can give an intracoronary also because the antiplatelet drug, but that is not needed. It's a rapid onset action. Whether you give or not, within 2 to 3 minutes, you are going to get adequate platelet action. But it will not make any difference.
Sridhar, I would also feel that a similar question was never asked when we talk of heparin, whether heparin should be given intravenous cath lab or intracoronary in the cath lab, and we all give intravenous.
Yeah.
If you want to give intracoronary, no harm. I mean, you can give like we give intracoronary heparin also. But I don't know whether there is any study which tells you that it is makes a better impact.
The uses of this molecule is also, if we see that the systemic use is there, not a localized use much better. So do you feel like this also, sir?
No, wherever you ultimately, even if you are putting it to the coronary also, it will reach to systemic circulation finally. Okay. But because of the onset of action, you see some drugs, when you give IV, so they have to reach to the coronary. But here directly within 2 hours, you are getting the PRU units, adequate platelet activity. So I don't think, but if you want, as sir mentioned, you can, there's no harm in giving intracoronary also directly.
Okay. Sir, what do you feel if a patient is having major thrombus burden? Should we load this patient with the cangrelor in place of P2I12 orals, keeping in mind further incomplete reperfusion and possibility of surgery?
Thrombus burden definitely, mostly thrombus burden, lack of adequate. Suppose clopidogrel is on, it may be clopidogrel non-responder or low responder. In such cases, better to give this drug. See that you are getting adequate antiplatelet activity.
No. The question is probably trying to ask us, like you inject into a right coronary especially, and you see the entire right is loaded with multiple thrombi and some contrast sort of the right coronary artery. Now, in those cases, I guess this drug would be more effective. Whether to give intralesional, like we give heparin in the distal RCA, is another issue. But I guess it will get modified as you use more and more of this.
So one question is that what do you feel cangrelor as a bailout drug when the patient is on clopidogrel?
Yeah, like a clopidogrel, many times, particularly in India, in our subcontinent, definitely many patients are having a clopidogrel resistance. When the clopidogrel resistance, many times these tests are also not reliable. So many, almost 30%. So that's the reason many cardiacs, almost they are not using clopidogrel. They are going with ticagrelor. There's every cath lab now, the momentum is only for ticagrelor, and some subsets they use the prasugrel. But when the ticagrelor on and patient is having a thrombus or haziness is there, this drug should be given, definitely.
You know, I had a patient, as I mentioned to you earlier, we did an angioplasty on ticagrelor at 1 o'clock in the afternoon. At 10 o'clock, 415 stent in proximal LAD developed acute thrombus. And this is the only time I have issue of thrombus while on ticagrelor. Maybe some other reasons also played a role. We don't know. Okay, any more questions?
Yes, sir. This is last. I think it has been already taken. Coronary angiography revealed ostial obstruction of RCA, suspecting hypercoagulable state of patients. Please suggest your opinion.
No. I think there are two different issues here. RCA origin ostial narrowing. I mean, it has to be a cholesterol-related narrowing. If there is a thrombus in addition to that, making the lesion very tight, say 80% lesion gets to 99% because of this, and that's how the patient has come, you have to treat it as a combination of cholesterol and clot. So if you are going to use cangrelor, you can use cangrelor, not a problem.
The thrombus, we should, when intracoronary thrombus or stent thrombus, we should think in two. One is antithrombotic, one is like a heparin. Sometimes catheter direct thrombolysis will come. So if inadequate flushing is there, catheter thrombus may form in the catheter, may go and stuck in. So such cases, definitely inadequate heparin. And whether he is receiving adequate heparin or not, that also we should check. And simultaneously, is it because of the inadequate platelet activity? There are two things. So we should give a proper antiplatelet agents. Despite giving proper antiplatelet agents, if the patient is on thrombus, that means your ACT may be low. That also we have to address. Both should be given.
I think ACT is a very good guide to tell you whether your heparin is working or not working,
yes,
or whether you need to repeat a bigger dose on a given case. So I think ACT in cath lab is extremely useful for these kind of decisions.
Sir, I think 4 or 5 more questions are there, but I think I don't feel that this is unanswered. All the questions which are reflecting on the chat box has already been answered on that, sir.
So, good job, Sridhar.
Thank you very much, sir. A very pleasure to see you, sir. Really, always pleasure to share with you, sir.
My pleasure too.
So on behalf of...
Thank you all MSN executives and for arranging a wonderful meeting. Thank you very much.
Thanks a lot, sir. So on behalf of MSN Labs Private Limited, my heartfelt thanks.
Nitin, I must ask you one question. How is
Yes,
the
sir.
pickup of this new molecule? I mean, we were waiting for this molecule for months together. It was a little bit delayed in India compared to US, introduction in US. I would feel there was at least about 5 years gap between US and India. I don't know whether I'm correct or wrong. But how is the pickup? Is like Sridhar is accepting Cangrelor, I am accepting it. But the numbers are spreading. You're happy with the progress?
Yes, as I mentioned in the beginning itself also, sir, that now we have reached to almost 8 to 10% of the cath lab presence, sir. The beginning journey is like that in 3 months back, we started with 30 vials sale. Then we went to 120 vials. And this month till 17th only, we have crossed almost 120, sir. So we are expecting to go more than 200, sir. And
this is faster than any cardiologist growth, isn't it? I mean, a cardiologist doesn't do 4 cases in at the end of 6 months and then goes to 30 cases at the end of 1 year. But this is really a very fast spread. We
fact, sir, I will not say only this is all the cases, because some of the cases they have gone up to 2-3 vials also, because at 8 to 10 cases of the bridge therapy also we are getting in a month also, sir. So in some of the cases they are going up to 2 to 3.
Whatever it is, I mean, people are sort of understanding the indication to use.
Yes.
And I think that's a big achievement. We must, I'm sure Sridhar joins me in congratulating you and your team on this kind of very aggressive growth.
And into day-to-day basis, sir, we are maintaining a data of who has prescribed. So now we have reached to the numbers 90, sir, all across India. And they are all masters, sir. Wherever it is being used, sir, that is the big thing for us, sir. Because it is spreading all across, sir.
But as sir mentioned, if you improve the awareness about the indication, particularly high-risk subsets, definitely your number is going to pick up very fast. But I think
from tomorrow, expect 5 times growth.
Yeah.
So I think keep enough stock.
Sure, sir. In fact, this is our self-manufactured product, sir. So stock is not a concern, sir, because just in between, I would like to mention this thing, sir, that sir knows that thing very well, that we belong to Hyderabad as a company only, sir. And we have brought so many molecules for the first time. And we have got the Asia's largest R&D facility also available near to Hyderabad, sir. So we would like to welcome both of you, sir, if you can spare some time to go to our R&D facility to show you this.
If there agrees to come, I'm coming.
Sir, please. It will be our pleasure, sir, if you can invite him from your behalf, sir.
Sure.
Thank you so much, sir. So on behalf of MSN Labs Private Limited, my heartfelt thanks, gratitude, and first of all, respect to our Hiromet sir to spare this much of time and grace this occasion. And on the same time, I would like to thank you for Kasturi sir also for giving this much of enlightened talk. So this is clearing all the doubts of all the cardiologist level. And my sincere thanks to all audience also for putting so relevant questions, which is relevant to all the cardiologists and clearing all the doubts of this as a new molecule, sir. So thank you very much from my side, sir.
Nitin, I feel this is a molecule which is at the top end. Very selective people would use it. And you have to sort of encourage more and more people to use it. So if you can see the cath labs have spread far and wide in India. And you would never get cath lab in a town like Baramati or Satara in US. But in India, you can. So I would feel this can be marketed very well, very comfortably in smaller labs too.
Sir, Kasturi sir, you would like to add something?
Yeah, sir, already highlighted. I think if you don't hesitate, even in some labs, you can keep on consignment basis because when they understand, definitely they are going to use and more. But availability, Suppose if a really sick patient, that only in few, like when emergency is there, doctor will not see anything. How fast he can shift the patient to cath lab. Suppose if an inquiry, if the vial is not available, he will not wait for it. He will try to finish the procedure. But see that during that time, during crucial time, the drug is available. If that time is there, then doctor will try to use the drug. So they don't hesitate in using.
You know, this is a question of demand and supply.
Yeah.
So I'm sure people like Nitin who want to supply very profusely, wholeheartedly,
Yeah.
they would be wanting more people like you asking for it, you know. So maybe today's presentations sort of improve people's acceptance in the mind of this particular molecule. And we all continue to use it in a big way.
Thank you so much, sir.
Thank you, sir.
That's all from our side, sir. Good night, sir.
Okay,
Thank you
good night.
all. Thank you for being with us today.
Thanks a lot.
Good night, everyone.
Good night.